I think there are two cases. One was like a continuation of one that we started before and we never finished. And then there is another one new that I uploaded last night. So I don't know, which one do you prefer? They're both interesting. Any votes, one way or the other? I don't think they're gonna be long enough to have just one case. That's why I uploaded the second one, because I think we are gonna probably they're gonna be relatively short. So I think we're gonna have enough time to go through both.
Yeah, last week's unfinished business first.
Okay, I like that attitude. Okay, so let me. Okay, so let me go back here. So I think this one was case 68.
Should we start? Yeah, I agree.
And the history was a 7-year-old Labrador with acute abdominal pain, vomiting, depression, and anorexia. And let me bring the images up. As usual, let me just copy that so I can share the link with you. More chat. So that's the link if you want to open the images. No, that's not the right link. So it's the same. Copy. Okay. That's the link. And let me bring the images up. There were a bunch of images available. I'm going to select 2 or 3. Maybe we can have a left lateral, right lateral, and then we can have a VD. There we go. And if you want me to go through, I don't know if this one is, I mean, the cranial abdomen is not included, but we have the cranial abdomen in this radiograph. Oh, but that's a left lateral. Let me see if this is a right lateral. Yeah, again, half of it is out. So we have the thorax as well. So if you're interested more in the cranial abdomen, I can always bring the thorax there. But I think probably the best we can do is to go like this. Left lateral, right lateral, which would be this one. Yeah, and then VD. Middle-aged dog, acutely painful in the abdomen, vomiting, depressed. I'm trying to find my pen, so then I start writing your comments. Normal or abnormal?
Abnormal.
Okay, I agree. one day, and you know, I think, I'm not sure, but I don't know if this is that I'm dreaming because I wanted it to be like that, or actually it was like that. I remember before the boards, I think they told us that they would not put a normal. And we were all like, oh, because it's a huge component in the real life, not in this case, but sometimes, and the classic case is the animal is very sick. There is a lot of pressure for you to find something. Makes sense? Because everyone is waiting for you to give an explanation, and the radiographs are normal. And having the guts, you know, yeah, you know, saying this is abnormal. I'm not saying that the dog is not sick. I'm saying the radiographs are normal. We need to be looking somewhere else. It's not an easy call. So I promise I will not bring normals, but sometimes that call is not easy. And defending that call sometimes is extremely difficult because, again, there are huge number of diseases that they're not going to result in any radiographic change. And the animal may be dying, makes sense? So there is that pressure for you to find something to explain the problem, and then there is actually nothing there. And so to be able to defend that normal, and in an exam, I can't even tell you, If you throw a normal, you're gonna be trying to find small things and making up many things. Yeah. Anyway,
Oh God.
why is it abnormal?
There's a increased soft tissue opacity in the region where you would normally expect to see stomach and like just caudal to the liver. I'm not sure if I can see two renal silhouettes,
Okay.
but I'm also not sure if I can definitely identify both ends of the spleen.
Okay.
And I think maybe I can see gas on the VD that might be within the stomach. And I can maybe convince myself, I can see an outline that might be stomach superimposed on a soft tissue opacity on the left lateral, but I'm unsure about that.
How have you tried to figure out how to draw the images? Because you usually go on the phone.
I do, but I'm like branching out and using the laptop at the moment.
Oh, cool.
So hang on, let me try and work it out. It's gotta be here somewhere, right?
So probably out of the things that you mentioned,
Yeah.
I'm more interested in. I'm interested in everyone then commenting on your remarks. So there were three different comments. One was spleen, the other one was the kidney. But the one that I'm interested in you showing us, or somehow drawing on the images, is about the soft tissue, what you call a soft tissue opacity, and then that kind of issue that you had in between deciding if that is a real soft tissue something, or if that it was the stomach, or I'm interested in showing you, not in you being correct, but in showing us what you see and what is your question mark, or what is your thinking, and how far you can go.
So my question mark is that soft tissue mass within or part of or continuous with the stomach? Or is the stomach superimposed on it? And that the outline that I'm looking at on the left lateral, I think I've just decided that maybe I'm just looking at ribs. So I was kind of looking there. Whoop, sorry. Pen malfunction.
So see if you can erase and come back, because now you know how it works.
Yeah. All right.
Good.
Oh.
Now let's start from 0.
Okay. It's a bit more complicated than on the phone.
Okay. So you're putting all of that together. Okay.
But I think when I look at the other views, even though like the front bit's cut off on the right lateral, I think maybe the lines I'm looking at are actually just the ribs, and I'm kind of imagining that that's where the stomach would be.
Okay. So you're saying I see something there, but I'm concerned that I may be making that up using the borders of the ribs.
Yeah.
And then also my brain may be tricking me because I have the expectation of the stomach being there, and then I can just make an image up. Okay, yeah. So I think it's a good time to open the discussion and then let other ones contribute to that image. And as soon as we define it a bit better, my suggestion is when you are a bit lost, which you have the right to be lost in a situation like this, I think you need to go back to the principles, and then the principles are going to be whatever I'm seeing, even before deciding where it belongs to, makes sense. Where is it coming from? You can try to describe it and use the different features, and the features are the size, the shape, the opacity, the location, the margination. Makes sense. So you can say, is that bone or metal or soft tissue or gas or a combination? How big is that? How well defined? Where is it located? Makes sense. So at the end of the day, the more you can describe that, then even unconsciously, you are, even without being aware of it, you're going to be already removing some of the considerations that in the first, when you first look at the images, may be coming to you. So, okay, so what we're going to do next is someone taking up this comment and seeing if we can move us a bit further. Probably there's going to be some degree of disagreement, but then let's go that way. And then Jennifer, you can come back and then say, counter argue, you know?
Okay.
I'd say the mass, or if it is a mass, the area of soft tissue density that is of concern probably extends slightly distal and caudally to the outlined area. And my other comment would be that the intestines seem to be crowded away from the cranioventral abdomen in a caudal direction.
Jennifer, was that convincing?
I agree completely, which I guess is one of the reasons I was a bit borderline about whether that outline really was the stomach or whether I was seeing things.
I mean, you don't need to be defensive. This is the way it works. Someone brings something and then, you know, we keep going. So yeah, but there were two interesting points. One is that actually the outline of the mass seems to be running from a different line compared to the one that you draw. And then the second point was there seems to be not only a mass, but there seems to be a mass effect.
Yeah.
This displacement of the small bowel. Very, very interesting descriptions, because yeah, this is I completely agree, and I think somehow this is tricky. But okay, my next question would be, if we all agree on that the mass seems to be located more in the cranioventral abdomen, and it seems to be displacing the small intestine caudally. The next thing that I would like to go through is, what is the opacity of that mass?
Soft tissue.
Okay, are we all in agreement with that?
I
I think
agree.
there's some like
Yes.
very tiny little bits of gas opacity within the, if you look really closely, there's some like tiny dots of gas in there. Maybe.
I agree. So this is like a soft tissue opacity structure, and that's the liver. If you mind, Jennifer, do you mind removing your annotations?
Sorry.
It's okay.
Why won't he erase?
Cool. So now that I magnify a bit, so I think I will probably draw a line around that mass, like somewhere here. And inside, it seems to be not only soft tissue, but also gas. And then that's why I really like that comment about the small bowel being displaced, because this gas is based on the distribution and the shape of the gas. It's not within the small bowel. Makes sense that gas within the small bowel is more elongated. This kind of the classic shape. This is gas that is not within the GI, or it could be within the stomach, I suppose, but not within the bowel. So it's not that we have superimposed small intestine. It's that I think that mass has a mixed opacity. The next thing that I will do will be to try to figure out where is that mass located in the other projection. Makes sense? So we are narrowing down. Now we know, we are more confident that there is a mass. We know that there is both contains some gas and is soft tissue. We know where it is in the lateral projection. Where is it on the BD projection?
I think you can see it because of the displacement of, well, maybe not the stomach. You can see the cardia of the stomach, but the displacement of the intestines and the location of the tiny little gas opacities suggests it's there, I think.
Beautiful. I completely agree. So it seems to be, if we want to be described a bit more, so then a key element here is that it seems to be caudal to the stomach, and we hopefully this is already ringing some bells. You know, we talked about the stomach as being a structure that helps us decide about, you know, where things are coming from. So it's caudal to the stomach. It seems to be more on the right side, and in the same way, similarly, in the same way that this displacing the small bowel caudally, it seems to be kind of impinging or somehow going against the stomach more cranially. Okay, so now we know a lot more. There is a mass with mixed opacity. There is in the cranial right ventral abdomen. There is displacing, there is caudal to the stomach. Any other feature that you want, that are you interested in discussing? Anything else? We haven't talked about the margination. We haven't talked about the borders. Do you think they are well defined? Do you think they are ill-defined? Do you think they are regular? Do you think they are irregular?
I think they look quite well defined on the laterals, and they're rounded, but there's a few, I guess there's a few areas, so sort of here and oops. And on the other lateral, you can see similarly clear margins, but I find it more difficult to be clear with the margin on the VD.
Good, I agree. And I agree in some areas it's well defined, in some areas it seems to be kind of undulating, but in some areas like here, I think it's not so well defined. So if you compare this border with this border, and the reason why I want to make that, I guess the reason why we want to be slightly picky in this point is because we are trying to, at the end of the day, how well we can see the borders is telling us if there is fluid or not. Makes sense? So if there is associated fluid or not. So if we see the border being slightly ill-defined here, I think based on this, at least that image, I would be very suspicious that there is some degree of free fluid. And that is, I think, is a game changer. Makes sense, even though it's a subtle change. I think it's an important point to put it back in context with the dog being painful and being depressed. Okay. Okay. Anything else that we want to describe? Anything else that you want to add?
I don't like the appearance of the intestines. I feel like there's two populations of small bowel, or the cecal area. If it may be cecal area might be displaced from the right to the left side, and I can see colon where it's descending, but I can't see the transverse colon. And if the accumulations of gas is the transverse colon, it's more. It doesn't, I guess it's not in a straight line. It looks quite plicated, well, bumpy, and not where I would expect to see it.
Okay, good, good. So you identify something you described. You already offer, I suppose, 3 options, as far as I could recall. So one option is that it's small bowel. And if that is the case, then I suppose you are concerned because there are 2 populations. The other option that you considered is that colon, and now the reason why it looks like atypical is basically what is abnormal at the end of the day is the location. And then for that, I have the explanation that there may be the mass displacing the colon. So that's the second option. And I guess there is going to be a third option running there, which will be something primarily wrong going on with the colon. I don't know, you haven't mentioned, but I could think about an interception or something like this. So I agree with your findings. So there are these mainly gas-filled bowel loops, which are which diameter is larger compared to the small bowel, which seems to be sitting in the left cranial abdomen. So given the options, which option would you consider? Which option do you think is more likely?
I think it's definitely displaced by the mass in terms of where it's located, but the appearance, I still don't see how the mass can explain the bunching appearance or the fact that it's full of gas. Yeah, I'm still concerned about those 2 parts of it.
Okay, so you're not really buying the option of, because I could argue back and say, for the explanation, for the idea of that being displaced colon, there are a couple of things that really fit. First, those things are displaced to the left, and the mass is on the right. The mass is in the cranial abdomen, and we know that the colon likes to go there, but the mass could be displacing this colon caudally. And then when you displace something and there is less room for that something, it can be a little bit more twisted or has a bit more of a curvature or loops. So I would probably, for me, that would be enough to, well, we are never 100% sure, but to be pretty sure that otherwise, to be pretty sure that is a colon. A way to argue against would be where if that is not the colon, I'm trying to find another evidence or another point to support that idea. Another one would be, well, if that is not the colon, where is the colon? Where is the transverse colon? Where is the cecum? Things that we usually see. Makes sense? So I would probably go both ways, and that would be the reasoning that I would use to maybe conclude with some degree of certainty that is very likely the large bowel that is being displaced by the mass.
Okay.
But I mean, this is exactly the exercises, and that's why I leave you describe everything, because everything that calls your attention is worth mentioning, and then we try to unpack it. You know, we try to explain. Anything else that you want to bring in the description? Once we finish with the description, we are gonna. It's kind of the end of the hard part of the report, and now we are trying to guess. Makes sense? You see how now that we have all these findings, how are we going to put them together? And that's a guessing exercise. So before we go into the guessing exercise, is there anything else that you want to comment on?
I don't know if it's worth noting here, but you really love this part about it, Mariano, but the gastric axis seems to be a bit more kind of vertical here. So I'm just wondering if that means that potentially the liver is smaller, or if potentially the stomach is just empty and that's a factor. I'm not sure if we kind of touched on stomach.
No, that's perfect. And I somehow mentioned that, but without using the word gastric axis, which I think that's the way to do it. It seems that the stomach, if anything, when there is a mass in the cranial abdomen, we immediately need to look at the stomach and decide, is it caudally displaced, is it in the normal position, is it cranially displaced? Usually, when it's caudally displaced, simply we just blame the liver. In this case, it seems to be, if anything, a bit cranially displaced. And your reading of that being the possibility of a small liver or an anatomical individual variation, deep-chested dog, are perfect considerations and extremely important. Yeah. I would have one more, and probably we will have came to this point anyway, but I think that my brain is kind of telling me like, is that mass, we've been calling it mass, it looks like a mass, it's acting like a mass. Then we are going to try to figure out where is it coming from. But it has mixed opacity and it has gas. And that's something that I don't like in the abdomen. Makes sense? Because then we are going to go through the things that can result in production of gas in the abdomen. But what I would be desperate to try to figure out in this case is, in the same way that I was suspecting free fluid here, is there any free gas? Makes sense? I think that's a very important point that you may not be able to answer right away, but you should be concerned. Makes sense? Because then we are dealing with something, a disease process that is producing gas, and probably it's not only that, but it broke into the peritoneum. So the question is, do you see any evidence of free gas?
I don't think so. I think no.
Okay, I agree. I don't think so. What if you really want to answer the question? In other words, do you think, how likely do you think is that you're missing free gas? And this is just to recall, like a discussion that I would probably have in the clinic, or I would have if I'm home and someone is working on this case. I would probably ask them, because that is a very important concern. I mean, it's very important to be sure if there is free gas or not. I would probably ask them, and I answer the question that I asked. I think it's very easy to miss a small amount of free gas. I would probably use a horizontal beam in this case. Makes sense? So how it works is if you look at this lateral projection, the animal is actually laying on the side. Makes sense? So it's going like this. And then you have the X-ray tube up here. So if there is any free gas, it's gonna go on top, on the upper part. That gas in this radiograph is gonna be somewhere here. This is maybe the most, the upper part when the dog is laying on the side. If there is a minimal amount of gas there, that may be superimposed with the rest of the gas, and you may not be able to make a call. So anytime you have a question, and usually it's a very important question, and it's very important that you answer that question with certainty about presence of free gas or not, then what you should, in my eyes, or is in the book, and it works, what you should do is a horizontal beam. So you turn the dog like this. So this is the table here, okay? So you put the dog on the back. You wait a little while. You give enough time for the gas to move up. So if there is any free gas, it's going to accumulate here. And then you don't take a BD projection. You take a lateral projection. Makes sense? Like this, like you take a lateral projection with the dog laying on the back. That is called a horizontal beam. And basically the image is going to be something like this. And then there's not going to be superimposition. If there is gas, it's going to accumulate up here, and you will be able to separate gas that is free from gas in the GI tract. So I hope I was clear enough. If I wasn't, I really recommend going through that information. I'm happy to then find another case and then go through that in detail, because that is extremely easy, extremely cheap, and super valuable, like in a case where you are after free gas. And probably, Ross, if you're around, if I were an examiner, I will be playing with that idea. This candidate knows about radiographically how to rule out free gas. It's very simple, super useful, takes 1 minute, super cheap, and it's something that we need to know. Makes sense? So it's easy to miss. Finding free gas is very important. It's very easy to miss it. The way to find it is to take a horizontal beam. There are multiple positions that you can use. There's a later paper and where they found that this one is the best. Dog on the back, lateral projection using a horizontal beam. If there is free gas, it's going to accumulate here, and then you will be able to separate. Then there is no more superimposition between that gas and GI gas. That's the concept. Okay, I felt the need to communicate that.
How long do you need to leave them on their back?
I don't remember if that is in the paper, if anyone actually studied that. I would go like my grandmom when I remember asking her about cooking recipes. She said 5 minutes. And I would make the same comment. I don't know if that's the right number, but I would probably position the dog, make sure the dog is comfortable, and then after that whole process, maybe wait 1 or 2 more minutes. Makes sense, to make sure that there's enough time for the cat.
But do you quickly push them onto their side and take a lateral, because we can't change the location of the plate?
Well, so no, and that I already have a comment that unfortunately, if you have so now we're going to technique. So in the early days, when you had like the analog, this was a piece of cake, and it was very easy. You just put the plate next to the dog and you move the tube. Usually the problem is not to move the tube around. Usually the problem is to move the recorder, makes sense, the cassette or the receptor. So in the old days, easy. If you have DR, then it's easy because again, you have the cassettes. So then you move things around. If you have DR, like we have in NBS, so there is the option. That option, the option is you can remove the plate. That option is usually loved because the plate is so expensive that when you buy it, the vendor is gonna tell you, he's gonna ask you, do you want me to leave it in such a way that you can take it out and play around with it? And most of the people buying this equipment, because it's so expensive, is gonna say, no, 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 no. Fix it there. I don't want anyone being able to remove this from the table. And I think that's the way that we have it. And I completely understand the point, but this is limiting this ability to play with the cassette. Or not the cassette, it's the detector, the plate. If you go in equal medicine, basically now the plates, or I remember the one that we bought at the uni last days, was even wireless. So that was it was still DR, makes sense? So this is the plate, the detector, but there wasn't any wire attached to that plate. You could actually move it around and go anywhere and then take a radiograph, and then it will show up immediately in your computer. So I don't know in your particular practices, the system that you have is in theory possible for in any type of situation. It may be purposely locked because it's $100,000 and then you don't want someone throwing that on the floor. Makes sense? So, but yeah, I would probably think about having a way to unlock it, and then in a particular situation, being extremely careful, being able to use this capability. Okay, let's continue with the case. So now is a guessing exercise. What could it be? So as a summary, there is a mass with mixed opacity, with undulating contours. There is a suspicion of mild amount of free fluid, and it's located in the cranioventral abdomen, mostly to the right of the sagittal midline. So that's the summary. And now is the guessing exercise. What could it be? And actually, in the summary, we should probably bring also the clinical signs and the signalement. So all of this in a 7-year-old Labrador with acute abdominal pain, depressed, and with anorexia.
I think the
sorry, you get one.
thanks. The gas makes me concerned there's necrosis or infection in it. So it could be a necrotic tumor or in the spleen, or it could be TORS. But I think to get necrotic from a torsion, probably the dog would be dead. So probably a necrotic tumor. I think it's probably spleen because we can see the liver, because of the gastric axis, we can think it's probably not the liver, and it's caudal to the stomach.
Okay. Yep. Those were all good points. I will probably push back a bit on the idea. I like the idea that you are bringing necrosis into the game. I will probably push back in the idea that you need necrosis in a torsion. I think in a torsion, because of the vascular issue, there may be gas within that torsion, whatever, without the need to have necrosis. Makes sense? Because of the vascular issues, because of the compression of the venous return and the continuous arterial supply. So I'm not 100% sure about this, but I don't think it's necessary. In other words, I think we can end up with having fluid within a torsion, gas within a torsion, without having to wait that long for the necrosis to show up.
Right.
The necrosis, I like the necrosis together with the possibility of a neoplasia, and then a superimposed infection, for example, an abscess, something like this. So that is perfectly fine in that list.
Given we've already decided that the gas isn't free in the abdomen, and we have a linear pattern there, I would assume that has to be the colon, if all those things are true.
And therefore, then how you're gonna use that information?
Yeah, because the mass there has variable radio opacity.
You got muted.
I'll stick my neck out and go for an hemangiosarcoma.
Okay. Yeah. And so how are you going to put the gas in that context?
The gas is in the bowel.
Okay, I see. So now you're saying, I'm not sure that gas is within the mass. Maybe it's just superimposed. And then there's just a hemangiosarcoma in the spleen, which is also soft tissue. I think I would listen to that option. And I think it's very hard to prove you wrong. I personally believe that there is some of that gas that is within the mass. And therefore, I would probably also consider something like an abscess or a torsion. But I understand. And then while you were describing that linear gas opacity, I'm not sure that is colon, but I think another consideration that we should have is this mass actually originating from the colon? Make sense? And then because you're originating from the colon, there is going to be some degree of communication of the lumen of the colon into that mass. I think that's an option that we should consider.
If the gas is free, then we also have to consider an intestinal rupture.
I agree. I don't think it's free in this case. It's kind of contained within that mass. But then an intestinal mass, either from the colon or from the bowel, I think there are good differentials. Something in the spleen, along the lines of a neoplasia with a secondary infection, abscess, and then gas. We went through the torsion, and I think it looked different. This is more like rounded. Probably, I don't know if we want to still keep it there or not. Any other differential? I suppose something coming from the stomach.
I may have missed it at the start because I missed the first minute or two wrangling children, but was there a fever and were bloods done?
Let me go back. I think there was.
I mean, I guess I'm thinking infection or neoplasia or something else.
Yeah.
And, you know, they can sort of, the signs can, or the results could overlap. Might give you some pointers, I guess. I
completely agree. I don't know if there was fever, but it was abdominal pain. And I need to make clear, I would before getting, if I would be in the clinic, I would probably be making very clear that all of these considerations are probably just academic. Makes sense? Because I think we have already enough to send this dog to surgery. Makes sense? Because there is a mass with gas inside in the abdomen, and there is a bit of free fluid. So I think now we are speculating, as we did last time, you know, what could it be? And trying to see if we have hints to move forward. But probably we already know what we should be doing in this case. Or as usual, knowing more is going to get us more prepared for the surgery. Or if we know more, we may even decide not to go to surgery. Makes sense? So, but the exercise of trying to bring as many differentials as we can think about, I think is a good exercise. And I agree with you, along the lines of neoplasia, torsion, infection, like an abscess, granuloma. Okay.
The abdominal pain is not consistent with my hemangiosarcoma theory, so probably have to discount that.
Well, I don't know. I agree with you, but probably I would say maybe it's an unusual presentation. Maybe there's a torsion on top. I don't know. So what to do before I give you the answer, probably it would be a good idea to think about, like, if you are in the best of the worlds and you have all the money and the owner is like, say, told you, I want to do everything I can to make sure that I don't send the dog to surgery and then you need to euthanize on the table. What would you do?
I think an ultrasound exam would be useful, or a CT, or even both.
Agree.
I agree. So I think first line, cheaper, non-invasive, no need for sedation. I would put a probe And I think you get already a lot of information, things that we were considering. Where is it coming from? You may or may not decide. I don't know. It's not going to be for sure that ultrasound is going to give you that answer, but probably you can at least say, is the spleen okay? What about the liver? Can I see a connection with the stomach? Can I see a connection with the bowel? So I will give it a go like that. And either if you don't find the answer, or if the owner is really committed to knowing for sure and not leaving any stone unturned, then I will probably go with CT. But the disadvantage would be I would need anesthesia or sedation, and probably to have in order not to have questions, I would need contrast. Yeah. So I think that's the scenario. And I'll give you the answer because it's a very uncommon thing. And I think we've done very well. And I don't think there is any way to be sure about this differential diagnosis and to be able to say, I know it cannot be this, it cannot be that. Makes sense? So I don't think we can bring the list of differentials any shorter than we've done. But just for the interest of you, just to share with you, I'll give you the answer. This was a hepatic lobe torsion. So it's kind of breaking some rules, and that's why I liked it a bit.
Which lobe?
Say it again.
Could you repeat what the diagnosis was?
It was a liver lobe torsion.
Uh-huh.
So one of the rules that is breaking is at least the rule that I love, but I always bring the exception to the rule, which is lesions in the liver displace the stomach caudally.
Caudally.
That is a rule, and it works most of the time. In this case, it didn't work. I suppose it has to do with the torsion, and then probably moved caudally, and then it grew, and it got bigger, and then it couldn't come back. Maybe because it's the right, I don't know, but it broke that rule. And I think there is some degree of fluid. So I think that's why I think it can explain everything. And I think, again, the presence of the gas, I don't know if it's because there is long-standing and then necrosis, or if because it's an abnormal blood supply, and then there is an issue there with the blood supply resulting on the accumulation of gas. I'm not sure which one is the mechanism. But I thought about sharing this, which is we were going through the theme of torsions. And we still have a couple of torsions to go through. I will make sure that we throw them into our cases. But we went through colonic torsion, splenic torsion. Now was the time for a liver torsion, liver lobe torsion. Very unusual. Again, I don't know you should make the list of differentials any narrower than we've done. But it's just to share like an interesting case.
Mariano, can you see the spleen in any of those x-rays?
I think so. I think I can see it here. I don't know why sometimes the spleen doesn't go across the midline, and then we don't see it on the lateral, but I believe this is the spleen.
Okay.
But the idea of this being in the spleen, is perfect. There's no way to argue against that idea in my eyes. So if you say, I don't want to remove the splenic mass, I would say, perfectly fine. You should not. Makes sense? Because even if you see the spleen here, that's the dorsal part. That's the dorsal, the left dorsal part of the spleen. And this is on the right. So it could
be in the tail.
Splenic mass. Yeah, absolutely. I would never remove that from the list of possibilities. Yeah. I thought we would go, it's an interesting one. I enjoy how you bring the features and then there is time to discuss about them. So we are taking long per case, which is exactly the way to go. So maybe there is not enough time for the second case for today, but that doesn't matter. We talk about it next time. Any questions, suggestions, agreements, disagreements?
Mariano, at some point, because I'm very unused to doing this, can you send details? I don't understand how people are able to draw on their screen and that we can all see it.
Yeah, so can you see my arrow?
Yes, I can.
And do you see this toolbar?
Yes.
Do you have that toolbar on your computer?
Well,
Because that may
It'll
be
say
the,
view options
sorry.
at the top of the screen. It'll say view options.
Yeah, I've got that.
If you click on that, there's a tab that says annotate. And it brings up
No.
the toolbar.
so once you have this toolbar, then you click on annotate.
Right. I've got standard side by side. I don't think I'm looking at the same thing. Don't worry, I'll play around with it during the week. And see if I
because
can-
we have a couple of minutes, and if we can, this is good because everyone should
I've
be able
lost you.
to draw. So you may have a PC.
On my On mine, when I click on the drop-down arrow for view options, I get a list starting with zoom ratio, request remote control, then there's annotate, then exit full screen, side-by-side mode, which is what I'm using. If you click on the annotate, then another toolbar comes up, and you can choose to draw, or you can use an arrow. And then you can also choose the color you want to draw in under format. There's a colored box. And then when you're finished, you just press the bin that says clear and it goes.
I haven't got that. I've got in my view box, I've got standard side by side, swap video and shared screen and exit full screen.
Not that view box. So
Not-
if you go to the top, if you kind of put your mouse right at the top, it might kind of pop it down. There's like a green bar that says you are viewing Mariano Makara's
Yep.
screen.
Yep, got that.
Right of that, there should be a little thing that says view options.
So to the right of that, yes, got it.
View options. not-
Yes, now I'm with you.
And then
I'm
you
with you.
press that and then annotate.
Annotate, got
There's
it.
another one that says view on the far right, which I can see now. And I was like, oh,
Yeah.
yeah, that's what I'm getting the same options as you.
Yeah, no, I'm with you now. So now I've got something
Yeah.
that says mouse, text, draw, stamp, arrow, eraser, format, etc.
That's they're all your options to kind of annotate in various ways.
So if you select draw there,
Yeah,
like click draw and then select one of the options, maybe this one. Now you are with me. You can see my screen. So draw.
I've just drawn a blue circle.
Perfect. So we are all on the same page now.
Okay, fantastic. I'm happy.
No, that's very important. So we can all discuss. And then there are some people that, pull their hairs out of their heads if you draw on images. I think if you're a professional, and the reason why they don't like people drawing on images is because you should be able to describe without pointing. And I'm all about that. But that's later, Now we are really, our attention is all about trying to figure out what's going on, trying to share what we see. And more than anything is that sharing. So then others can agree or disagree on draw on top. So I don't care about that. I think the ability to draw and to share what you think and how you see is very important. So that's why it's very important that everyone feels comfortable about being able to draw on the images and explain what they see. So very important.
Right. Brilliant.
But excellent.
Thanks
So now-
again, Mariano and NVS.
Very
I'm off
good.
for the school drop-off now.
Excellent. Now we start working.
Yeah.
Okay.
Yeah.
Have a good day, everyone.
Yeah.
You too. Thank you.
Thanks, everyone.
Bye.
Thank you.